All right, good morning, everyone. Welcome to another Friday morning AMSSM Sports Ultrasound case series. This week we have Dr. Riley Burke. Dr. Burke is a fellow at Geisinger Medical Center in Danville, Pennsylvania. He completed his undergraduate degree at Penn State University, medical school at Virginia College of Osteopathic Medicine, a family medicine residency at Elgin Air Force Base, and then he served as an active duty Air Force attending physician supporting special operations for 8 years before he began his fellowship this last year. He's going to be presenting on Subscapularis Tendon Pathology. So go ahead, Dr. Burke.
All right, thank you so much. And thank you to the AMSSM for the opportunity to speak today. I just want to make sure you guys can see my screen before we get started here.
Looks great.
All right. So today I'm going to be talking about subscapularis tendon pathology, and we're going to start with a patient, it's a 52-year-old male who was reporting shoulder pain and a popping sensation. I have no disclosures for today, but I will say that this topic was covered by the fellows at Swedish Health last May, and their presentation is another excellent resource if folks are looking for other presentations on subscapularis tendon on the AMSSM YouTube channel. The objectives of this case are really to review the ultrasound protocol for complete evaluation of the shoulder, to review images of a complete shoulder diagnostic ultrasound, to review pathology associated with this case, and then to discuss and review content of a diagnostic ultrasound report. So again, we have a 52-year-old left-hand dominant male truck driver who's referred to our diagnostic ultrasound clinic for a diagnostic ultrasound of the left shoulder. The patient was seen in urgent care the day prior for the sensation of left anterior shoulder pain with a popping sensation while he was turning a wrench. He had no history of a fall, but noted a sudden pain at the anterolateral shoulder when he lifted a heavy object about 5 days prior to presentation. He reported 2 out of 10 pain at rest and 8 out of 10 pain with shoulder flexion and abduction greater than 90 degrees. He had tried over-the-counter pain meds. He was prescribed a lidocaine patch and had tried activity modification with minimal relief in his symptoms. On physical exam, he had no swelling, ecchymosis, or deformity of the left shoulder. He had tenderness to palpation directly over the bicipital groove. He had a normal passive range of motion. He had weakness and pain with resisted flexion and abduction. He had a positive Speeds and Yergesen test and normal sensation. On external and internal rotation views, which were performed at the urgent care, it showed a slightly decreased acromiohumeral interval, but otherwise without fracture or significant osteoarthrosis. The Y and the axillary views were also grossly unremarkable in this case. And so just getting into the ultrasound portion of this came directly from the AMSSM Sports Ultrasound Scanning Protocols, which were last revised in 2021 and published in the BJSM. So our protocol is pretty close. I think our technique and patient position may be slightly different, but our technique and our protocol mirrors this directly. Before we get started, I just want to point out something briefly that the anatomic dissection photos are consistently right-sided, while the transducer position photos, the protocol ultrasound images, and the case images are all left-sided. I really hope this doesn't create any confusion, but thought it was helpful to corroborate our ultrasound images with the gross anatomy dissections. So that being said, let's just get started with our protocol. We typically start, as most people do, with the biceps tendon. We generally have the patient supinate the forearm. They'll flex their elbow and rest their hand on their lap, and then we'll use some gentle internal and external rotation to optimize our image and get that biceps tendon and short axis centered on the screen, which is shown right here. In order to properly visualize the bicep, you also need to usually toggle your transducer slightly cephalad in order to get a good crisp picture of that biceps tendon and the bicipital groove. It's also important to note that the long head of the bicep courses medial as it inserts at the supraglenoid tubercle. So you also need to adjust your transducer to make sure you're remaining perpendicular to that as you kind of traverse proximal along the tendon. Next, we'll slide the transducer distally, assessing the integrity of the tendon until we reach the pec tendon that traverses over top superficially. And then after we're done in short axis, we'll go back up to the bicipital groove. We'll center the bicipital tendon on the screen, and then we'll rotate it 90 degrees to visualize the tendon in long axis. When we're in long axis, we often are required to kind of heel in that distal portion of the transducer, again, just to optimize our image. And in this view, we're really just looking for evidence of tendinosis, tearing, proximal ruptures, tenosynovitis, or any type of dislocation or subluxation. From the bicipital groove, we then slide the transducer medial to assess the subscapularis tendon. As shown in this long axis image, we typically use the coracoid process as the medial anatomic border for our image. One key to completely evaluate the subscapular tendon is ensure that your patient has full ability to externally rotate. And a lot of our patients don't. And so I think that's fine. I think you just have to make sure that you're annotating that in your ultrasound report, saying that you were unable to get a maximum visualization of the subscapularis due to limited external rotation. So we'll get that image in long axis, and then once we're satisfied with that, we'll rotate into short axis, and you'll see this multi-pinnate pattern, which typically gets or can sometimes get confused for tearing in folks who are novice sonographers. But we scan through that tendon in short axis as well. And what we really want to make sure is that we're scanning and sliding our transducer in a caudad to cephalad plane to make sure that we're getting the entire width of the tendon in that caudad to cephalad plane. This portion of our exam will do the dynamic assessment of the biceps to look for subluxation, dislocation, and coracoid impingement. So as we're playing this, we're just kind of externally rotating the shoulder there, and we're just kind of watching that the subcoracoid impingement view, and then just making sure that there's no wadding or balling of any of the subcoracoid bursa as we're externally rotating the patient. From here, we're basically going to assess the coracoacromial ligament. You can see this gross anatomic dissection that represents both the anterior and posterior bands. This is our ultrasound image here with our coracoid here and the acromion here laterally. So basically what we're going to do with the transducers, we're from our position looking at the subscapularis. We're just going to basically rotate that lateral aspect of the transducer up to the acromion to get that picture. From there, from the coracoacromial ligament, we're going to rotate the medial aspect of the transducer clockwise for the left or superior fashion in order to visualize the acromioclavicular joint, which is shown here. Here we're looking for cortical regularity, capsular distension, or a geyser sign in the setting of a large rotator cuff tear. And just a few things to consider when scanning the AC joint is to make sure that you're decreasing your depth to optimize your image here. And then again, to scan in that anterior to posterior plane to make sure that you are assessing the entirety of the acromioclavicular joint. From the AC joint, we'll slide laterally, the transducer lateral, anchoring the medial aspect of the transducer on the lateral border of the acromion process, and the lateral aspect on the probe on the greater tuberosity. And this will give us a nice picture of the subacromium subdeltoid bursa. And then we will again do the dynamic semiloop just to look for any wadding or pulling or impingement of that supraspinatus as it slides under the acromion process there. And in this patient, it was normal. After assessing the subacromial bursa, we'll have the patient transition to a modified CRAS position. We'll put the transducer over the greater tuberosity pointed posterior and oblique towards the patient's ear. And the supraspinatus will typically have this bird's beak appearance and it'll have a kind of bony footprint that is often described as a ski slope. When capturing semiloops of the supraspinatus, we aim to start our image anterior at the long head of the biceps to ensure we're scanning the entire width of the tendon from a anterior to posterior plane. From the supraspinatus, you will slide the transducer posteriorly, and you'll appreciate subtle changes at the confluence of the supraspinatus and infraspinatus. And as you transition towards the middle facet of the greater tuberosity, you're going to notice that the bony footprint begins to flatten out. And the infraspinatus tendon has a little bit more of a relatively thinner and wide appearance when compared to the supraspinatus. And you can see that represented here with that flattening of the bony landmarks and just a wider, flatter appearance of the infraspinatus. While maintaining the patient in the modified CRAS position, we'll then rotate the transducer 90 degrees to view the rotator interval. And the rotator interval is really just a triangular space bordered anteriorly by the subscapularis and posteriorly by the supraspinatus. Although the rotator interval is most commonly used to confirm and measure rotator cuff tears from the long axis, this graphic also really highlights the complexity and the nuance of this area and all the anatomic things that you can identify further when assessing the rotator interval. From the rotator interval, we then have our patient relax. They transition to the posterior glenohumeral evaluation, and we just tell them to basically put their hand on their contralateral shoulder. And as you can see, we're at the transducer position here. We are getting this image, and we're really looking for any kind of posterior glenohumeral joint effusions, any cortical changes that may represent a Hill-Sachs type of lesion, paralabral cysts, or subtle labral pathologies. This view can also be used to assess the myotendinous junction of the infraspinatus as it kind of comes around the humeral head. And for patients who are relatively lean, we can often get by with using the linear transducer. However, in central Pennsylvania, where we often have folks with higher BMIs, we're often required to use our curvilinear to just get an adequate assessment of this glenohumeral joint. From the glenohumeral joint, we'll just simply slide medially to briefly inspect the spinoglenoid notch. And really, again, we're looking here for any cyst in this spinoglenoid notch or any other space occupying lesions. From the spinoglenoid notch, we'll slide our transducer superiorly to this scapular spine to visualize the scapular notch, which is shown right here. Again, we're looking for any space occupying lesions. And we notice that this notch is bordered superficially by the transverse suprascapular ligament, which can be appreciated really nicely here in our gross anatomy model here on the left. From there, we slide to the muscle belly of the supraspinatus in the short axis by placing the probe superior to the scapular spine and perpendicular to the course of the supraspinatus. In this view, we're assessing for fatty infiltration and muscle atrophy. This is typically graded on a scale of 0 to 2. Healthy muscle should appear isoechoic with a kind of that normal pinnate pattern, where patients with fatty infiltration will have increased echogenicity with loss of discernible pattern. And this can be extremely helpful for your surgical colleagues as they're trying to make plans for whether this patient would be ideal for a rotator cuff repair versus a total shoulder replacement. We do a similar evaluation for the infraspinatus muscle belly by simply sliding our transducer below the level of the scapular spine. And from this image, you can appreciate from superficial to deep the deltoid, the infraspinatus, and then the bony infraspinous process or fossa there. The teres minor is generally easier to find. In short axis, it's a little bit of a challenging muscle and tendon to identify. We typically start in the short axis. And so from that view of the infraspinatus, when we're assessing that muscle belly, we slide the probe slightly caudally to visualize the teres minor in short axis. You'll notice that the muscle will appear a bit smaller with an oval cross-section and a much narrower intramuscular tendon. Once we identify the teres minor here in short axis, we'll rotate the probe approximately 90 degrees, which should be roughly 30 degrees oblique to the scapular spine, which is shown here in this probe position, to evaluate the teres minor tendon and long axis. And this really differs from the infraspinatus. The infraspinatus is going to have a much broader, wider, thinner footprint compared to the teres minor, which is going to be much more shortened and stout compared to the infraspinatus. So now that we've walked through our complete shoulder protocol, let's return to a few of our key case images. In this video of the bicep tendon and short axis, you'll notice that the bicep tendon here is really perched medially on the lesser tuberosity. So I'm just going to play that a couple times through, but you don't see that sitting nicely in the bicipital groove as you'd expect when you start. So we're already a little suspicious that something's going on here. As we first scan through the subscapularis, we notice that the bicep tendon again appears kind of embedded within the subscapularis. And maybe there's some mild cortical irregularity, but otherwise, there's nothing really we can discern much more. As we continue to scan the subscapularis tendon and long and short axis, we appreciate this large hypoechoic interruption of the distal and cephalad fibers with few kind of intact bursal-sided and articular-sided fibers. I'll play that again. This is consistent with a high-grade interstitial tear kind of at the distal insertion here with a suspected SGHL tear, superior glenohumeral ligament tear. But as you can see, the coracohumeral ligament is intact right here, it appears to be based on this image. Sometimes if we're not sure, because anisotropy can be a significant challenge with scanning the subscapularis muscle, sometimes you can just note the volume loss that occurs across the muscle, which can further confirm the presence of a large tear. And this is just that tear redemonstrated on short axis. You can just see not only the volume loss, but this large hypoechoic defect consistent with a high-grade tear. This in my loop, I'll play a couple times through, but what you'll notice is as we have the patient externally rotate, the biceps tendon will have this, it's getting ready to happen right now, have this really sudden dyskinetic medial dislocation of the long head of the biceps, just with gentle external rotation. So this is what the patient was describing when he was coming in to be evaluated in urgent care. And as we were scanning him, this basically reproduced that sensation that he was experiencing, which had him come in for evaluation. Transitioning from the subscapularis, we'll go to the supraspinatus. And in long axis, you can appreciate this large hypoechoic defect at the footprint with this kind of hyperechoic, I'll play that again, hyperechoic tendon stump, which is consistent with a complete tear of the supraspinatus with retraction, which we measured at approximately 1.04 centimeters in this still image on the right. On long axis evaluation of the infraspinatus, we noted a partial articular sided tear. Kind of here at the insertion, you can see that hypoechoic kind of a spot right there at the insertion. And when we flip to our rotator interval here, we also measured the width of that rotator cuff tear or the supraspinatus tear that we had saw on long axis, and we measured that to be 1.44 centimeters. Looking at this patient's muscle bellies of the supraspinatus and infraspinatus, he showed no signs of significant evidence of fatty infiltration or atrophy. As you can appreciate in both of these images, the muscle is relatively isoechoic with a fairly normal pinnate pattern. And this was also compared to the contralateral side. These are a few basic details we'll include in our ultrasound report, typically the patient, the MRN, the ordering provider, the performing interpreting physician, where it was performed at, the date and time, and then any comparison imaging that we have. This is a copy of our ultrasound report. I'm not going to go through it all, but I will just highlight some of the high points from the assessment. We noted first that there's a dyskinetic dislocation or instability of the long head of the biceps tendon due to a partial subscapularis tendon and supraglenohumeral ligament tear. There's a high-grade interstitial tear of the subscapularis at the distal insertion, complete full thickness tear of the supraspinatus with retraction, partial articular sided tear at the insertion of the infraspinatus, subacromial bursitis, mild AC joint joint osteoarthrosis, and then no evidence of fatty infiltration of the supraspinatus or infraspinatus muscle bellies. This is an MRI, which basically confirms the same. On this coronal T2 view here, you can see this retraction of that supraspinatus. And on this axial view here, you can see the biceps again perched over that lesser tuberosity and this T2 hyperintense signals, which represents that subscapularis tendon tearing. This is basically an MRI, which just described what we just talked about. They did define this as a type 3 extraarticular medial dislocation of the biceps, long head tendon into the subscapularis muscle tendon, which was shown on our ultrasound images. Just to give you a better idea of what this looks like, I think this graphic clearly illustrates a type 3 subscapularis tear, where there's basically a complete tear of this superior glenohumeral ligament and a large high-grade interstitial tear of the subscapularis, which allows the bicep to basically dislocate medial. So treatment outcome for this patient, the patient underwent a left shoulder arthroscopy with arthroscopic rotator cuff repair. He had a subacromial decompression and open subpectoral biceps tenodesis. He underwent 8 weeks of physical therapy with near full strength and active range of motion at 6 weeks post-op, and he returned to truck driving at roughly 6 weeks post-operatively. Before we wrap up, I just wanted to highlight a few points that I thought were helpful to further understand the subscapularis pathology. First, although the supraspinatus typically gets a lot of our attention, the subscapularis is actually the largest rotator cuff muscle, and it's a powerful internal rotator of the glenohumeral joint. It really serves to provide anterior stability against anterior-inferior translation, and really our surgeons really value it because it promotes humeral centering. So if they end up repairing a supraspinatus, but they don't address a subscapularis tendon tear, there's a high likelihood that that repair will fail. This anatomy illustration here gets a little complex, but I think it's super important to understand the relationship between the subscapularis and the biceps tendon. At the superior-most insertion of the subscapularis tendon, at the upper medial margin of the lesser tuberosity, it's going to insert right near the intertubercular groove. But then you're going to have this tendinous slip, which is represented in this yellow shaded area here. That's going to basically kind of tuck behind inferior to the biceps tendon. And then you're going to have that insert into this orange portion here, the fovea capitis of the humerus. And then you're going to have that supported by the superior glenohumeral ligament and the coracohumeral ligament. And that, in fact, will basically create like a function of like a trochlea or a pulley, which serves as the main restraint to keep that long head of the bicep from dislocating medially. So without this mechanism, that biceps, as it sharply curves towards the supraglenoid tubercle, it's going to want to just dislocate medially. Another key point is that given the relatively large size of this subscapularis, the subscapularis has a relatively large but tapered insertion area, which measures at approximately 2.41 centimeters squared, which is compared to this supraspinatus at 1.55 centimeters. As you can appreciate from this graphic here, the cranial 2/3 is a tendinous insertion and is much wider than the caudal 1/3, where the muscle attaches to the humerus almost directly by way of a thin membranous structure. Given the large insertion area of this tendon, I think it's critical that we're systematic in our evaluation of the subscapularis. Finally, in an effort to make today's presentation more meaningful, I've consolidated some of the current literature regarding subscapularis tears with a few points that I think are worthy of mentioning. As highlighted in our case, first, most subscapularis tears do not occur in isolation, but are combined with pathology of the posterior-superior cuff, which is namely the supraspinatus or infraspinatus. And a prospective longitudinal study found that concomitant full thickness posterior superior rotator cuff tears and 76% of shoulders that developed subscapularis tendon tears over a 5-year scanning period. They also noticed that development of subscapularis tendon tears may correlate with pain, where pain was reported in only 45% of shoulders with other rotator cuff tears, but normal subscapularis tendons on ultrasound, compared with 67% of shoulders who reported pain with other rotator cuff tears and a subscapularis tendon tear. Sonographic evidence of long-headed bicep disease was present in 71% of the shoulders that they scanned with concomitant subscapularis tendon tears, compared to 12% that did not have any subscapularis involvement. And finally, the most common pathology, about 63% of this seen on ultrasound, was medial subluxation or dislocation of the biceps tendon. To bring this full circle, our diagnostic accuracy of detecting subscapularis tendon tears has been relatively underwhelming historically. In this 10-year systematic review and meta-analysis published in the Orthopedic Journal of Sports Medicine in 2021, They compared the accuracy of diagnostic MSK ultrasound to MRI. And in this study, they found ultrasound to only be about 30% sensitive in detecting subscapularis tears compared to 89% sensitive for supraspinatus tears. The specificity for subscapularis tears was quite good at 97%. So by hopefully understanding the pertinent subscapularis anatomy and a systematic scanning protocol, we can continue to improve our sonographic acumen in diagnosing subscapularis tendon pathology. So these are just a couple of key points. First, subscapularis is a powerful internal rotator, which provides anterior stability of the shoulder. It appears multipinnate on short axis and shouldn't be confused with tear. You want to get in-range external rotation and long axis. And you want to make sure you're sliding cephalad and caudad and short axis for complete evaluation. This distal subscapularis forms a tendinous slip, which combined with the SGHL and CHL forms a stabilizing sling for the long head of the biceps tendon. The long head of the biceps tendon instability indicates a subscapularis tear until proven otherwise. Isolated subscapularis tendons or tears are rare, and the development of subscapularis tears are often associated with increased pain. These are my sources for my talk. And I just really wanted to thank Dr. Matt McElroy and Brian Scorsone for their help in preparing this case. They are both exceptional sonographers and teachers, but more importantly, they've been wonderful mentors this year for me. Thank you for your time and attention this morning. I'll pause for any questions or comments.
Gosh, Dr. Burke, that was fantastic. You really knocked that one out of the park. I don't have a ton of comments, you know, as I oftentimes like to give some pearls after these. But gosh, you covered most all of the things that I would normally want to bring up on this. I think, you know, one of the things that you highlighted and that I want to just raise in kind of the whole purpose of the series is having that systematic approach to the shoulder. And, you know, what can frequently happen is you get excited because you find something, especially when you're starting to scan initially, right? Oh, I found a problem with the biceps. It's in the wrong spot. And the exam ends there because you've figured out the problem. But really having that kind of systematic approach, you know, as you mentioned, 75–80% of subscap tears have a supraspinatus tear associated with them. And so you want to make sure that you're kind of following that systematic approach, and you highlighted that really, really well. I think you also, you know, brought up the complexity of this area. And I always think the shoulder's interesting, and it's that, like, it's the thing that we always talk about in sports and MSK ultrasound as like I scan shoulders. And I think that's because it's relatively well contained. You can scan the whole joint in a pretty good protocol, as opposed to like the elbow where it's like circumferential and it's more challenging, more structures. But the shoulder is actually really complex. There's a lot of pitfalls with anisotropy. Understanding the relationship between the subscap, the supraspinatus, the superior glenohumeral ligament, the coracohumeral ligament, the biceps tendon, and how that changes as you scan from proximal to distal is really quite challenging. And I commend you on, you know, your assessment of this. That was a great pickup and a great call. Understanding, you know, what structures are injured to cause that pattern. You know, the biceps tendon can dislocate into the joint. It can dislocate into the subscap tendon. It can dislocate superficial, and all of those indicate a different injury pattern. And understanding that relationship, I think, is really essential. The only other things I would maybe add is, if I had someone with this sort of pattern, I would probably take a little bit closer look at like the subcoracoid impingement and really try and figure out, is that a problem? And you did, so you kind of can a little bit do both the biceps tendon instability exam and the subcoracoid impingement at the same time, but making sure that that's really focused. I will oftentimes also scan down towards the pec major and just make sure that we didn't miss anything with the pec major as well, even though that's not part of the standard protocol. But you really highlighted adding in kind of those additional ligamentous structures in the anterior shoulder that aren't always a focus of our standard shoulder exam, but should become a primary thing that we evaluate when we see a pathology in the anterior shoulder. And then the last thing I'll mention is there is kind of one potential pitfall sometimes with this, in that the supraspinatus can have this aponeurotic expansion, which looks like a secondary biceps tendon running down, and it's usually superficial and lateral to the bicipital groove. But just understanding that there can be, if you're scanning that biceps and you see something a little bit unusual that looks like a second biceps tendon, that can be that supraspinatus aponeurotic expansion that you'll occasionally see. I think that's all I have. I don't know if anyone else in the audience has any questions. I think Dr. Cruz had to hop off. All right, fantastic. Well, once again, great job, Dr. Burke. That was great. We will be back again in a couple of weeks. On April 21st, we have Dr. Wills from University of Iowa presenting on the EHL. Thank you, everyone.